Good morning, everyone. My name is Brooke Phillips. I'm the Marketing Manager with Shield Healthcare, and I'd like to welcome you to today's webinar on fall prevention for older adults, best practices to reduce fall risk. Just a quick overview. For older adults, falling can lead to far more serious consequences, including long-term hospitalization, disability, or death. Yet with best practices for assessment and preparation, many falls are preventable. In this webinar, we explore assessment techniques and living modifications to help reduce fall risk. Before we begin, just a few housekeeping items. Attendees will be in listen-only mode. If you have a question, please type it in the question box on the right-hand side of your screen. A PDF of the presentation slides is also available as a handout that you can download from the webinar. If you registered as a healthcare professional and would like to receive CE credit, look for an email from Capital Nursing Education containing your CE certificate within the next 2 to 3 weeks. If you miss any portion of this presentation or would like to share it with a colleague, the webinar is being recorded and will be available on shieldhealthcare.com/community by the end of this week. All right, right now I'm delighted to introduce Kelly Sparks, RN, BSN, CWOCN, CFCN, as our presenter today from Capital Nursing Education. Kelly Sparks has been a CWOCN for over 25 years and a nurse for more than 30. She's worked in wound, ostomy, and continence care for most of her career. She's been on the board of directors of the Pacific Coast region several times in the past, as well as being on multiple projects for the WOCN Certification Board. Kelly is active with the local Sacramento WOC Nurse Group, where she serves as secretary. She's recently retired from Dignity Health and continues with her private practice. Kelly has been a speaker for many different conferences and classes. She enjoys speaking for Shield webinars and working with Capital Nursing Education to help promote education necessary for the care of patients. At this time, I'd like to pass the presentation over to Kelly. Kelly, it's all yours.
Thank you so much, Brooke. Good morning, everybody. I hope that everybody is safe today and everything's okay with your families. I'm just really excited to do this one. We have a lot of stuff to talk about with reducing fall risk with elderly. And I just want you to know that it's a beautiful day outside. And so I'm just delighted to be here. We'll start by looking at our objectives here. So first of all, we're going to work on understanding the magnitude of the problem because it is a huge problem. Developing an understanding of the risk factors related to falls and investigating different risk assessment tools. Learning there's some 3 key risk factors for falling that we're going to go over, and also go through some community and educational resources as we go along here. So, you know, there are some very serious consequences from falls. And like Brooke said, for older adults, falls can lead to more serious consequences, including hospitalization long-term, disability, or even death. And so it's, there's so many preventable falls, and we need to look at what is preventable by using our best practice for assessment and preparation. So in this webinar, yes, we're going to explore the assessment techniques and some modifications that can be done to really help to reduce the risk of fall in our elderly population. Other consequences, there are so many other consequences. And in a study published by the Journal of Trauma, Injury, Infection, and Critical Care, Dr. Julius Ching, he stated that adults 70 plus are 3 times as likely to die following low-level falls, and that's compared to their under 70 counterparts. So his study found that there was 55% increase in the rate of fatal falls for elderly adults because of the increase of the general population. So just because the general population is increasing, it does show an increase in our falls, of course. The negative effect of age on health outcomes has been well established. We know that. And pre-existing medical conditions do play a huge role in the ability to recover from these falls. So looking at this slide here, 4.5% of 70 plus age patients died from ground level falls. compared to 1.5% of non-elderly patients. So ground level, we're not talking about grandpa that gets on the ladder and climbs up onto the roof to do some work. We're talking about ground level. So that's huge. They are very, very costly. 1 out of 5 falls causes broken bones or a head injury. And each year there's 3 million older people that are treated in our emergency departments for injuries. Over 800,000 patients a year are hospitalized because of fall injury, and most often because of head injury or hip fractures. And, you know, of those 300,000, that's just from the hip fractures. And usually those are caused from falling sideways. Usually they fall, when the hip fractures, it's from falling sideways. The other falls are the ones that cause the traumatic brain injuries. So yeah, it's very, very, it's huge. And we need to protect our elderly and, you know, try to come up with ways to keep them from falling. So there's long-term consequences. Many people who fall, okay, even if they're not injured, they become more afraid. They're afraid of falling. And this fear is what causes a person to cut down on their everyday activities. So then they become less active, they become weaker, they become, they just completely increases their chances of falling again because they absolutely are afraid. So therefore they just get weaker and they fall again. So 22% were able to function on their own when they're discharged compared to 41% of non-elderly. So it's really, really, it can, well, I can put it this way. I have a 10 speed. I fell. When I fell on my 10 speed, I'm afraid to get back on it. I'm not young. I'm really afraid. So I ended up having to get a 3-wheel bicycle. And yeah, I look kind of funny going down the street, but it's out of that fear. And if I didn't have that 3-wheel, I wouldn't be going at all on my bike. So you just have to prevent it in the first place. And the key is prevention. Instead of just treating falls as they happen, the focus should be on what we can do to keep these older people from falling in the first place. So before we can tell who is at risk, we need to know what the fall risk factors are. So, and what can be done for this so that we can keep them from falling in the first place. The World Health Organization, that I'm sure you're all familiar with, identifies 4 categories of risk factors, and you can see them here. The first one, biological risk factors. That's going to include the aging, the gender, the race, the chronic illnesses, and physical or cognitive defects. So number 2, the behavioral factors such as multiple medication use. They may have excess alcohol intake, lack of exercise. Those are your behavioral risk factors. Then you have your social and economical risk factors, which could include things like access to adequate housing and community resources, services, and social interaction. These people a lot of times don't go anywhere, and so they're not getting this that increases their risk factors because they become depressed and then they don't move at all. Environmental risk factors, that's huge. It could be at home or in the neighborhood. Poor building design, slippery floors, stairway, loose rugs, insufficient lighting, and we're going to go over some of these, and cracked or uneven sidewalks even outside. Some of these risk factors are intrinsic and some are extrinsic. So we're going to look at all these different things. Again, the fall risk factors that you see here, intrinsic and extrinsic. And medications, home neighborhood features, support from caregivers, footwear, assistive devices, alcohol and drugs. And then intrinsic would be your behavioral or your choices and your age-related changes, the gait, the strength, the balance, visual defects, chronic conditions, cognitive defects, acute illnesses. All of these things are risk factors that are very important to keep our elderly people from falling. We need to look at them. So looking at the intrinsic risk factors, the age-related physiological changes. A review of the literature shows that many healthcare providers believe that falls to be a symptom of a disease process or a drug side effect, unless these diagnoses are completely ruled out. Comorbid diseases such as osteoporosis, age-related physiological decline, slower reflexes, this type of stuff, and changes in their vision and their gait. Often these are associated with falls in the elderly. So for vision, when you get older, you know that reduced papillary response to light variation. So you walk into a room that is darker and it takes longer for your eyes to adjust to that. So there's thickening and loss of the elasticity of the lens. And then with gait, of course, the decreased step height, dragging those feet, and then decreased proprioception, which we'll talk a little bit more about that, and the balance with slowed riding reflexes, which means that as they start to tip, they have a slower reflex to right their body to get standing straight up. And then incontinence, so many elderly people have incontinence, and this is a huge fall risk because they're trying to run to the bathroom. They're going to leak on the floor sometimes, and when they do, they're going to slip in it. So, just hurrying can cause, somebody to fall, just trying to get to the bathroom. So behaviors and choices, like I said, when a person falls, it makes them very fearful to get up and move any more than they, and they become deconditioned. So that makes them weaker. And when they get weaker, then it leads to more falls. It is a vicious cycle. So that's why we need to keep our elderly patients and family members stronger, try to keep them on their feet longer. Then there's those who have dementia. They can't understand the importance of using caution and doing exercises, using the walker, etc. So especially men completely deny that it's a possibility that they would ever fall. They are too manly to fall. Men tend to feel like they're weak if they ask for help, so they don't ask for help very often. And some women are that way too. Some elderly women, they definitely are stronger than a lot of the nowadays women. It's just incredible what these women have been through. A lot of patients feel like they don't need physical therapy, they don't need occupational therapy, they don't need exercises, they refuse to do it. They just don't understand that the exercises are what keeps them from falling. Some think that, oh, you know what, I'm getting old. Why on earth do I have to do exercises? I'm not getting any younger, and you can't make me any younger. Well, you have to tell them, hey, it's not about making you younger. It's about keeping you on your feet, because once you don't use it, you will lose it. And then you become bedbound, and then there you go. So it's a matter of explaining to them, and a lot of times they just don't get it. So you have to use some, creative manipulation, like make it fun, or have them do something that helps you and it makes them feel like they're actually being helpful. Chronic illnesses, oh my goodness, that's a huge one. Arthritis, depression, diabetes, stroke, asthma, all of these things can contribute to falls. Chronic kidney disease, cancer, getting weaker, angina, a lot of chronic illnesses in our elderly, and we need to look at those when we're determining what are the fall factors, or what are the fall risk factors for these people. Medications, oh my goodness, they can increase the risk of falls so much, and this is an intrinsic one. Antidepressants in general. So it's important to note that most antidepressants, with the likely exception of like Wellbutrin, they can cause hyponatremia. And so that in itself is a risk factor for older adults. This fall risk may be due to their gait, their attention disorders, which can be found in elderly patients with hyponatremia. So we have to really look at that. Tricyclic antidepressants, they should be avoided in older adults due to their side effects. There's a lot of side effects with TCAs. Anticholinergic side effects would be things like confusion, cognitive impairment, delirium, mouth dryness of their mouth, constipation, urinary retention. All of these have an alpha blocking activity that can cause in itself orthostatic hypotension. So, and then there's antihistamine properties that cause sedation, impair their balance, slow the reaction time. So those things you need to look at. Common TCAs include things like desipramine, Pamelor, Tofranil, those types of things. And then you have your antipsychotics. We know they can be a problem. The Haldol, the Zyprexa, they can increase the fall risk due to syncope and sedation, slowed reflexes, loss of balance, and impaired their psychomotor function. Looking at the benzodiazepines, they're used for anxiety, things like diazepam, alprazolam, all of those PAMs and LAMs. We need to really watch with our elderly people. The antihypertensives in itself, that can lower the blood pressure enough to where they end up having, problems with balance, and all medications that are used for hypertension can increase fall risk. However, some classes are more likely to do so than others. So potentially safer alternatives would be your hydrochlorothiazide, angiotensin converting enzyme inhibitors like lisinopril, alpha blockers such as your terazosin. Those can cause the blood vessels, they cause the vessels to dilate. So that can cause your orthostatic hypotension. So that you really need to watch it with those. And they're also, these agents sometimes are used to treat BPH, and you have to really watch, like Flomax. Flomax can cause the orthostatic hypotension. Centrally acting alpha-2 receptor, perhaps clonidine. That clonidine should always be avoided in the elderly, because that can really cause the orthostatic hypotension. Your diuretics, they can cause orthostatic hypotension, and hypotension also increases with dehydration. So you really have to watch the people that are on your like hydrochlorothiazide. Loop diuretics are more potent than thiazide diuretics. So things like Lasix and Vuix, you really have to watch. It is huge with medications. That's one of the biggest fall risks for our elderly, or all these medications. And sometimes they're on so many. And if you look at their med list and you see all of these, sometimes it's multi-physician ordered too. So very, very careful. You have to really look. If the cardiologist orders one thing and their PCP orders another thing, they're going to end up with two different, antihypertensives. You're going to end up with a fall risk there. So cognitive defects, confusion, Lewy body dementia, Parkinson's disease, and depression. So depression is huge with fall risk. Poor health status usually, and impairments in their sensorimotor performance, and multiple medications. Consistently, you see that in people that have dementia also. I mean, it's especially people that have depression, you get some medical things. Lewy body dementia, that is so interesting. That is it's associated with abnormal deposits of protein in the brain, and they're called little Lewy bodies. It affects the chemicals in the brain that changes and can lead to problems with thinking and movement and behavior and mood. This is the one that Robin Williams was diagnosed with and committed suicide after finding out that he had that. Lewy body dementia and dementia-related Parkinson's disease, they've both been associated with higher fall risks. So, and injury was moderate compared with mild for dementia, but repeat falls was associated with severe dementia. So really need to look at what's causing that dementia as well, because it may be something very simple, or it may be something as bad as the Lewy body dementia or Parkinson's disease. So as we are all aware, acute illnesses usually come with fever, which can cause the dizziness and the confusion. Elderly people sometimes become confused with infections, like, you know how your elderly little ladies come in with a UTI and they're just completely have so much confusion, and that is just strictly from that infection. The fact that they are acutely ill means that they probably are on multiple medications, like I said, and some of them can cause the side effects that I mentioned earlier. So we need to really look at that. But acute illnesses and fall risk is one of the intrinsic risk factors that we, need to look at. Now we're going to look at the extrinsic risk factors that happen. This would be in the home, in the neighborhood, floors. Look at your floors. If you have an elderly person at home and you have slippery floors, you're in trouble. Throw rugs, my thing about throw rugs is nobody should have throw rugs. I mean, if you have somebody that's walking around if they have elderly people, throw rugs are so dangerous. Even if you double side tape them down or you use non-slip backing on these rugs, if you have somebody who walks on the forefoot, like most of your elderly patients, when they're walking, they're not doing heel toe. They're doing ball of foot, just scooting along every step. And when that happens, even with their walkers, when that happens, that foot can hit the edge of that little throw rug, and then you've got a fall right there. So, and they'll fall right over the walker. I mean, it's very dangerous. Also, anything in the way. I mean, elderly people sit in one chair. You know that. They like to sit in one chair. And you may go into somebody's house and see newspaper pile next to the chair. Maybe their drinking bottle is sitting there. They've got a bottle of water, whatever. A lot of times there's magazines and stuff on the floor that they want to be able to get to, and tripping over those. Towels are a big one. Shoes, magazines, boxes, blankets. Their blanket falls down. That's huge when they're sitting in their chair and they have a blanket on them and the blanket falls down and then they try to get up, not realizing the blanket is there. That is a really good way to fall. Any objects on the floor, pick things up off the floor. Do you have to walk around things like wires or around furniture? In my house, I do have an elderly father that I take care of. We had to make sure that he could get from point A to point B without having anything that he's going to, run into. Look at the things for outside. Sloped yards. What's going to happen there? They try to walk down the driveway to get the newspaper and fall on their nose. Crowded sidewalks, of course, right now, nobody's going out, so our sidewalks aren't too crowded. But in the big cities, when somebody tries to walk even to the store, and then the heavy doors, oh my gosh, some of those doors are really difficult to open. And if they don't have a handicap thing next to them that you can hit to open it, some elderly people cannot even pull those doors open. I'm not that elderly, but yeah, I have trouble with some of those heavy doors. Uneven sidewalks, again, with that shuffle walk that they do and they don't pick up their feet. I'm telling you, that is a huge fall risk. Even cracks in the sidewalk or curves, trying to get up a curve, you really have to watch that. So again, they don't do heel toe, they do toe. if you ever walked down a curb that you thought was not going to be quite as far as it was, and that jolt that you get in your back, I have felt that so many times, thinking that is a shorter curb. Of course, you know, with glasses, sometimes that can do that. A shorter curb than what it was. And I have seen people fall just from that. It's just, oh, you know, another thing is the footwear. If you look at their footwear, oh, this is just another related to home, extrinsic, and I already went through all of these things. So I'm going to just slide right through that one and go on to footwear. So always, always have to have good support shoes that fit well. If they don't, sometimes they can slip off. Speaking of slip off, slippers. Those slippers that you just slip your feet in and there's no heel, nothing holding the heel in. To me, those are hip breakers. That's what I call them. They're hip breakers because as they're walking, sometimes they walk right out of them and boom, they're going to fall to the side, which causes broken hips. Yeah, it's important to have very well fitting shoes and to keep them from sliding up and down on the heel. And also not to walk around on the slippery floors in their socks. A lot of them like to do that. You know, the low heels reminds me, I have seen people in their 80s walking around in wedged shoes that are, you know, 2 inches high at the heel. And it scares me to death. And there's also some little old ladies that still like to wear their great big spike heels. That's even worse. But the first time they fall, they're probably not going to be wearing those anymore because they'll probably have a broken hip and won't be able to walk in those. Lack of support with caregivers. You know, sometimes people don't think about what they need to do. Caregivers need to encourage independence in the elderly. They need to try to get the elderly person into the community, a community fall prevention program, or they need to have the MD order a physical therapist or an occupational therapist. One thing for sure is that when a patient refuses or doesn't have the support from caregivers, they will truly decondition. And that leads to falls, which leads to hospitalization, which leads to further deconditioning. And that leads to more falls. So you can see that little algorithm at the bottom of that slide. That just is that vicious cycle. So, you know, I have to say, I've said before, I take care of my father. And he asked me the other day, why do you want me to do these? Well, he's got a little dementia going on, but why do you want me to do these exercises? I'm old. I don't need to do these. I'm not going to get younger. And my question to him is, Dad, and we're very open about death and dying. That's just the way my family is. Dad, would you rather just go to bed and die in your sleep? Or would you rather be bedbound and be taken care of in a bed for the rest of your life? And he said, oh, I don't want to be bedbound. Okay, then you need to get up and do your exercises. Let's go. And he gets that for that moment. But of course, every day it's new to him. So it's deja vu the next day. Very important though, if we keep them independent, their life will be so much happier going on into the way elder age. It's just, oh, it's just wonderful when you can see somebody who can still walk and can still have a good life well into their old age. So that's why we do this. Best practices for fall risk assessment. There's different components that we use. Fall histories, very important. Medication review, again, we've got so many meds out there that can help with falls. Physical examination and a functional assessment and environmental assessment. These are components of a good fall risk assessment, and there are many out there. For the falls history, what's so important about this is how many did they have in the past year? Because again, that's going to tell how they have done. And what kind of symptoms are they having before they fall? Do they get dizzy? Is it a trip? Is it, did they just bend over to pick something up and have a little orthostatic hypotension? What happened? The location, where were they when they fell? Were they in their bedroom trying to reach something? Some people just fall out of bed trying to reach a Kleenex, things like that. Activity, what were they doing at the time that they fell? These are all very important things to look at for a effective risk assessment. Footwear, what are they wearing? How are they walking? Assistive devices, did they trip over their cane? I mean, if they don't use their cane right, they can trip over it, right? Glasses, on or off. Some glasses change how the depth perception to the point where you can't tell exactly how far you're stepping. Ability to get up after a fall. Are they able to? Time of day. Was it in the middle of the night, or were they just tired at night getting up to the bathroom? What was going on? And what kind of injuries they sustained and any medical treatment received. Did they end up in the ER? Did they have a head injury? And cooperation with witnesses, if able, for recurrent or unexplained falls. If you have somebody who falls continuously, it would be really nice to have somebody who has seen that, yes, they looked dizzy, or they lost consciousness. What happened? Did they just look like they fainted? Or, these things are important to tell what's going on with the patient. Unrecognized syncope, and what is causing this syncope, if you can find out. Documentation of falls history is a quality indicator for prevention and management. If you don't have this documentation, it's very difficult to tell how their prevention and management is working in the long run. A little bit about postural hypotension. Reduction in systolic blood pressure of at least 20 millimeters of mercury, or diastolic of at least 10 millimeters of mercury within 3 minutes of standing. Very simple to test. It affects about 30% of older adults in community dwelling adults. This can be alleviated by reduction of their blood pressure medications, or stopping the medications that have that orthostatic hypotension as a side effect. That is important so that you can make sure. Above the knee support hose can help, and also sleeping with their head bed elevated just a little bit. That can also reduce that postural reductions in the blood pressure. I think everybody should, when you get out of bed, sit down and look, just sit there for a minute, get your bearings before you take off walking. And we have to teach our elderly to do that. Before they have to hurry to the bathroom, they need to sit there and get their bearings and make sure they're not going to get up and pass out. Symptoms are, of course, your lightheadedness, blurry vision, headache, fatigue, weakness, syncope, or maybe totally asymptomatic. All of a sudden, boom, they're on the floor. So it's important to check that with your patients. And it's fine, you check their blood pressure when they're sitting, and then check their blood pressure again when they're standing. Very simple to do. There's this awesome evaluation guide for older adult clinical fall prevention programs, and it's called STEADY, which means Stopping Elderly Accidents, Deaths, and Injuries. The website is here. It's also in your references. It's a wonderful, great fall prevention program. Wonderful evaluation guide for older people. And I'm going to go over this just a little bit with you, because I think it is extremely important to know exactly how this works. So I'm going to use my cursor here and kind of point. You can see at the top, patient completes the Stay Independent brochure. I'll show you that brochure in a minute. It comes with this, the CDC developed this, by the way. I need to tell you that. The CDC developed this algorithm, and it details each step of screening and assessment, and it guides the interventions based on their level of risk. So first you have them do the Stay Independent brochure, very simple one, and screen for falls and or fall risk. The patient scores more than or equal to 4 on the Stay Independent brochure, or they answer yes to any key questions. Have you fallen in the past? If yes, how many times? And were you injured? Feels unsteady when standing or walking? Worries about falling? You ask these questions. And then if you move over here, if they score less than 4 and there's no to all those key questions, then you're going to go to this low risk portion of the algorithm where you're going to educate the patient, give them some vitamin D and some calcium, and refer for strength and balance exercises, maybe a community exercise or fall prevention program. However, if they, in the Stay Independent score, if they score more than 4 or equal to 4, or yes on any of those questions, then you're going to evaluate their gait, strength, and balance, and we'll go over this timed up and go and 30-second chair and 4-stage balance test. When they do those, if they have no gait, strength, or balance problems, again, you're going to go to low risk. However, you may consider going down the dotted line here, you may consider conducting this multifactorial risk assessment where you're going to review their Stay Independent brochure, falls history, physical exam, including all of those things that we talked about earlier. But if they do those and their gait, strength, or balance is a problem and they've had more than 2 falls, of course, you're going to manage it that way, the same way, the multifactorial risk assessment. If they had 1 fall with an injury, you're going to go there too. But if they had no injury or no falls, then they are at moderate risk. This is a great algorithm. It seems to work very well. And then, of course, if they are here and they go to high risk, you're going to educate them, do the vitamin D, refer to PT, manage and monitor their hypotension, manage medications, address foot problems, optimize vision, optimize home safety, and then again follow up in 30 days and reassess them. Transition to maintenance exercise program when the patient's ready. I want to say something here about physical therapy. I kind of skipped over that. But I want to say that physical therapy is awesome for these elderly people. First of all, they respond so much better usually to a stranger coming in doing exercise with them than their own family member. They really do. And of course they, complain about it afterwards, but they won't complain usually with that person. So it really helps to have PT come in and do exercises. Then that way they will leave you an instruction sheet and you can sit down and do those exercises with your loved one or whoever, your patient, after they leave, and they know that that's what they're supposed to be doing. The other thing is occupational therapy. Occupational therapy will come in and go through the house and figure out exactly what needs to be changed. I absolutely love that because they will tell you what to do to keep your loved one safe. And I'm here to tell you that, I thought I knew it all about what to do to keep my dad safe. And they told me some things that I never even thought of. So again, PT and OT, extremely important. STEADY is based on American Geriatric Society and British Geriatric Society guidelines, and it's designed to help healthcare providers integrate falls and the falls assessment and management into their practice. Input from practicing clinicians has actually been done as well. So it's a really wonderful thing. It highlights that even individuals at low risk can benefit from the primary prevention approach. And it helps to educate about fall risk factors and strength and balance and vitamin D, etc. So again, look it up. Here's the brochures that they have. It's all online. There's the Stay Independent brochure. It's a really good, wonderful thing to give you the information that you need. Well-known risk assessment tools. Again, we've been over these in other talks, but the Johns Hopkins is very good too. A lot of people like the Morse fall scale because it's very quick. We use that a lot of times in hospitals, and the Stratify risk assessment tool as well. There's several different kinds. So let's talk about how these elderly people feel about falls. Well, older people frequently think that falls are inevitable with aging, but they underestimate their own personal risk. It's not going to happen to me. I'm strong. I've never fallen before, so I'm not going to fall. Environmental and behavioral factors like rushing and being distracted and things like that can really, those are most often seen in falls. Intrinsic personal health factors are rarely recognized by elderly people. Oh, no, I don't have a problem at all. And, few will use the prevention strategies such as the exercises and balance and stuff like that. PCPs have a very, very crucial role in helping patients to understand the importance of those intrinsic factors in causing falls, and few of the older adults use those. You know what? It's like this. It's like I said, I'm old, I'm supposed to be old. And why am I supposed to be stronger? That's the attitude that they have a lot of times. And they don't get that it would make their life a lot better not to be in bed the rest of their life. They need that encouragement. They need to adopt prevention strategies to reduce their chances of falling. They need people, and they need people to really, help them with this. Less than half of older adults who fall talk with their care provider about it. They don't want to tell anybody. And guidelines specify that providers should ask all their patients age 65 and older about falls at least annually. And I'm impressed that the physician we went to last did a complete assessment. Now, I did go ahead and go over the physical therapy and the occupational therapy earlier, but here it is outlined for you here. Occupational therapists, they're going to recommend things like what kind of aids they need. But what happened with us is the grab bars. I mean, we had them up, but we needed more. And she pointed that out. You know what? They'll actually take the patient into the bathroom and have them show them how do of course they leave their clothes on, but show them how do you get into your shower, how do you reach your soap, how do you reach your shampoo, if they're still showering themselves, and most of them that are walking are. And they'll go over that and see if that is safe or not. Is there a shelf low enough that if they're sitting on their shower chair, can they reach the soap? Some people fall just trying to reach the soap. So they really do go through a lot of things to show you what it is that you need to do to make that safe. And again, with PT, they're just wonderful. They come in and they, especially if they goof around with the patient a little bit, make them feel real comfortable. They really can be encouraging to the patient. Assistive devices. Grab bars are great. Like I said, we had to put more up. They're wonderful. When we built our house, we even put it in our bathroom, anticipating aging, of course. And non-slip mats for the showers. That's extremely important. Sock donners are helpful because I have actually seen people who fell trying to put their socks on. Raised toilet seats are great. Shower chairs, a lot of people use those. Steady furniture. Most of the time when you have somebody that is elderly and they're at risk for fall, one of the first things that you see that should give you the indication that they are at risk is they're going to reach out and grab furniture as they walk by. And if you have a piece of furniture there, a chair perhaps, or something that's on wheels that they're going to grab to balance, they're going to fall. So you want to have steady furniture in their walkway, not in the walkway, but near the walkway so that they can steady themselves as they're walking along. Walking aids, tripod, canes, walkers, and chair raisers. A lot of times elderly people have trouble getting up and down out of chairs because their legs are weak. And that's, of course, one of the exercises that we do with them. But if the chair is too low and and it doesn't have arms on it, and they've had a hip surgery or something, the best thing is to get the chair raisers. You can actually get devices that go underneath a four-legged chair that will bring it up, 3 to 6 inches, and make it easier for them to sit and easier for them to get up and down. Seat lifts are wonderful for people who have bad knees, have a hard time getting up. I will say here, though, that I am not fond of the lift chairs that lift them up to a standing position. Okay, that is the hardest thing to get rid of. And I'll tell you why. Once you get one, they will never get out of that chair using their muscles again. They will use the chair and they lose their muscles. They will atrophy. It's best if you can keep from getting that type of chair for them until they absolutely cannot stand up. The seat lifts are, they're okay. It's a little better than that whole chair going up to a standing position. Reaching aids are great. I mean, if they want to still, I literally will make Dad go out and get his own paper, because I want him to continue to walk as long as possible. And he uses a reaching aid. He can't bend over, get it? Reaching aids are great. In fact, I have one in my kitchen because I can't reach to the top. Alarm systems, very, very important to have for your elderly patients. And there again, if they fall, they've got help right away too. And there's many different alarm systems. So the 3 key risk factors that should be addressed by everyone is the balance in the medication and the home safety. Those are extremely important. Requirements and incentives for the PCP, honestly, they get paid for this, of course, but a fall risk assessment is required as part of the Welcome to Medicare examination. And PCPs can receive reimbursement for fall risk assessment through Medicare annual wellness visits. So they receive incentive payments for assessing and managing fall risk through voluntary participation in the physician quality reporting system. So that's huge. And like I said, I was so impressed when our physician went through the whole risk assessment with my dad. I was absolutely amazed. Okay, looking at the examination element, of course, they're going to look at this orthostatic, the distance, visual acuity, they're going to test them, and they're going to listen to their heart, do the gait and balance evaluation, and also do an exam of their muscles and lower extremity. They'll also be going through a neurological examination where they'll do a cognitive screening, sensation, proprioception, muscle, bulk, tone, strength, reflexes, etc. And they're going to look at all of these things at that examination and make sure. They'll recommend evaluations including the timed up and go, the 30-second chair stand, and the 4 positions. Let's look at this tug. This is a test that involves timing the person standing up in the chair with armrests, using assistive device if they want, walking 10 feet at their usual pace, turning around and coming back and sitting down. If it's greater than 12 seconds, then they are considered high fall risk. That's an easy test you can do. The 30-second chair stand. This assesses their lower extremity strength and balance. So being unable to stand up from a chair at knee height without using their arms indicates fall risk. That's another very simple test. And they do these in the doctor's office without you even knowing that they're doing it. This stage balance test, 4-stage balance test, they stand in these 4 different positions, and each one progressively is more challenging. So if you look at standing parallel and then semi-tandem, and then tandem with the heel of one toe touching the toe of the other one, and if they can keep it there for 10 seconds, they're good. Single leg stand for 5 seconds. If they cannot do it unassisted for 5 seconds, that predicts injuries, falls, and that means to the side to break a hip. Key points to remember: multifactorial interventions that address many predisposing factors can decrease falls by 25%. And also, falls are common and they have adverse consequences that we already went over, but they're often very preventable. There are current guidelines that specify the primary care provider needs to screen these older adults for falls, and they will do it when they do their first exam. They should. And they should refer patients to clinical or community resources to address their modifiable risk factors, such as PT, OT, and stuff like that. 3 key factors that should be addressed, again, balance, medication, and home safety. If those 3 are addressed, then you're doing really good. There are some community and education resources here, the Center for Disease Control and Prevention, and the National Council on Aging, Caregiver Action Network, and Shield Healthcare Community. And again, their websites are all easy to find. This is my home. Enjoy that for a couple seconds because it's just beautiful and I miss it terribly. And that's the end of my part of the program. Thank you so much for listening. I appreciate it. There's references at the end of this program that you can also download. And I'll skip through some of those here. And I'll turn it over to Brooke, who is going to give you some additional information.
Great. Thank you so much, Kelly. Thank you so much. What a wonderful and informative presentation. Just a quick reminder for those who registered as healthcare professionals, CE credit certificates will be emailed to attendees within the next 2 to 3 weeks. If you do not receive your CE certificate, please check your spam folder and also reach out to us at marketing@shieldhealthcare.com so that we can assist you. Next slide, please, Kelly. Great, thank you. If you enjoyed today's webinar or found it helpful and useful, you can find more educational information on Shield Healthcare's online community. Our community site has over 2,200 educational articles, videos, and lifestyle resources, including recordings of wonderful presentations like this with Kelly. That content is provided by many contributors, including our lifestyle specialists, Erin Baker and Laura Cox, parents of children with special needs, and much, much more. We update our community site several times a week and encourage you to explore those resources. You can find them at shieldhealthcare.com/community. We also have several free educational booklets available to anyone at no cost, including Living Well with Incontinence, Living Well with an Ostomy, tube feeding guides, wound management guides, as well as guides for aging safely at home. You can find the links to request these guides also on shieldhealthcare.com/community. Great. And we'll now open it up for questions. If you have a question, please type it in the question box on the right-hand side of your screen. If we're not able to get to your question live today, we'll do our best to follow up with you after the webinar to make sure your question is answered. And we do have a lot of questions that have come in, so we'll just run through them and see how many we can get through in the remaining 7 or 8 minutes that we have left. Okay, Kelly, what are techniques used to reduce the fear of acuity following a fall? I'm sorry, the fear of activity following a fall. What are the techniques used to reduce the fear of activity following a fall?
You know, the first thing would be to make sure that that person understands that whatever caused them to fall is being addressed. For instance, if it was a fall because of their slippers, you're going to get rid of those slippers. We're not going to use those anymore. You're going to be fine, and help them to strengthen. That's the main thing is get back up and go. You know, just like when I fell on my bike, you know, you got to get back up and go. And mostly just removing what the cause was. Find out what the cause of the fall was. And once they understand that that thing has been removed, that medication has been stopped, you're not going to have that, you know, orthostatic hypotension like you did, or whatever it was that caused them to fall. And encouragement, and work with them. A lot of times the elderly, unfortunately, have, you know, their memory, short-term memory starts to go a little bit, which in this case is fortunate because sometimes they forget that they fell using that particular walker or whatever. But yeah, find out what caused the fall, get rid of that, make sure they understand that's gone, get them up right away and get their encourage them to get their to get their strength back so that they don't fall again. I hope that answers that question.
Thank you so much. Okay, next question. Can any of the causes you've mentioned so far, can they also be applied to a patient who is young in age?
Oh, of course, yes. If somebody is, oh, sure. Young people can fall just, well, not quite as much as elderly people because they have better reflexes and things like that. But if they have some kind of health problem or some kind of disorder, that they have lack of strength, or they have a balance problem, or even some type of, maybe they have a prosthesis. Yeah, certainly. There can be anything, tripping over anything outside, walking and not watching where you're walking and stepping off of the curb wrong. I mean, sure, they could fall. But there again, even with the young people, look at what it was that caused the fall and work on getting rid of that particular thing. If it's the shoes that this girl's wearing because she thinks she looks really cute in these high shoes and she's out on the grass somewhere and falls, yeah, get rid of those shoes, or just don't wear them at the grass. Be smart.
Great, thank you. Next question. When checking blood pressure for syncope, we take blood pressure when sitting and then again when standing. Do we take immediately when standing or wait for any time?
It's anywhere up to 3 minutes, I believe. I believe it is. And it's in the program exactly how to do it, but I think it was anywhere up to or before 3 minutes of standing. So, and that's the way to find out exactly what's going on with their blood pressure when they stand.
Got it, thank you. How do we know how much vitamin D someone should take?
I think it's 1,000 international units, but again, I would run that by your physician. But that's what I'm thinking it is. That's what I'm giving my father. And I did look it up, but I would definitely look it up and talk to your physician about that.
Great, thank you. Which healthcare professional would give the STEADY program, an RN, PT, or OT?
Well, you know what? They each have their own. They may have a totally different program, but the STEADY program is online. I would suggest it to anybody. If, like, for instance, with myself, I looked it up and I use a lot of the things in the STEADY program for my dad, where, and a lot of it is common sense as well. But the PT didn't mention any particular program, and each hospital has their own policies and procedures and their own, some, like I said, use them more, some use the other ones. So it depends on what is in that facility and what is, their policy and procedures. But you can go online and get any one of these, and the STEADY program, you can download those. I mean, they're wonderful. And I would check, of course, with your facility. If you're talking about a facility, if it's for somebody private at home, you can do what you want. But as far as your facility is concerned, make sure it's okay to bring in some type of product like that. If it is, I mean, the OTs and the PTs, they have their own that they use. I'm sure they have their own, whichever one of them that they're going to use. But I would go online and get it and look at it, because they're all about the same. They all have the same things. It's just in a different format. But still, you have to follow what your hospital or your facility is doing.
Great, thank you. What does parallel and semi-tandem mean in regards to walking or standing?
Oh, that's the test where the different positions. So standing with their feet together first and see, if they can do that. And then semi-tandem would be 1 foot back halfway, halfway the length of the other foot. And in other words, move the right foot back halfway the length of your left foot. And then tandem is where you're toe to heel. So it's hard to stand with your feet in that position. So, but that is the test. Yeah, tandem is toe to heel, and they need to be able to stand like that without falling.
Great, thank you. We do have a lot of questions. We'll try to squeeze in a few more. How do you overcome the denial of the person that a throw rug is dangerous? My elderly mother has neuropathy in her feet and says they are always cold. She will not get rid of any of her rugs.
Oh, that's so scary. You know, unfortunately, she may have to fall first, but hopefully not. I would get her a good pair of slippers that are not slippery, and definitely make sure that those rugs are held down well. If you use double-sided tape, I mean, like for me, I get rid of them all and I don't even ask questions. I remember my brother telling me this too. He went into my mom's house when my mom was alive. My mom and dad had throw rugs everywhere. And my brother, being a fireman, he was like, no, and he'd take all her throw rugs out and get rid of them every time he came over. But you can't always do that. I would say make sure that they are held down very well, double-sided tape, or you can get the non-skid liners that you put underneath that keeps them from sliding. You can get those online very easy. If she insists on having them, that's all you can do until that first fall. And then, sorry, Mom, they're gone. I'm not going to have you breaking a hip. You know, we'll get you some slippers that keep your feet nice and warm, and you won't have to worry about the warmth issue. You know, you're going to have to play with that one.
Great, thank you. Is there any way to get ahead of the fall by people having their hips checked ahead of time for micro tears, mild hip pain? Do physical therapists check on this, or are the primary care doctors who are aware the elderly fall that frequently?
Well, if they're falling frequently, they're going to be doing some x-rays, I would suggest, or I would guess. That's kind of a funny question, because I mean, if they did x-ray and they saw that there was some kind of little micro tear or whatever, or a little tiny break, you're going to just have to be more careful. That person's going to just have to be more careful, because if they do fall, that's going to crack more. You know, they're probably going to have a nice break. You just have to be careful and make sure that all of these risk factors are taken care of so that they're not going to fall. You can't ever tell if that person, if they haven't been x-rayed, you can't tell whether they already have some kind of injury there until after they fall and they get x-rayed or an MRI or something to see. So, yeah.
Great, thank you so much. We are 3 minutes past the hour, so we'll go ahead and wrap here. There are a lot of questions we didn't get a chance to get to, but we'll do our best to get back to you with answers to those questions as soon as we can. So thank you again. Thank you, Kelly, so much for a wonderful and informative presentation and for your time today. Thank you, everyone, for joining us, and we hope you have a wonderful rest of your day.
Thanks, Brooke, and I'll look forward to those questions.